All right, we're going to go ahead and get started. Thank you all for taking some time out of your day to attend our echo session. I'm really looking forward to our presentation. If you would, just enter your name and contact information in the chat. And if you want to share where you work or what your role is, that can be great for networking purposes. As always, we are recording this echo session so that we can upload it to the Canvas page. So by participating in this session, you are agreeing to be recorded. You are welcome to leave at any time if you do not want to be recorded. And we've been living in the Zoom world for a while, but if you want to rename your profile, there are some of our instructions on this slide or a reminder on how to raise your hand. There will be a discussion component later on where you're welcome to unmute. If you do want to raise your hand, it's along the bottom of your screen in the reactions option. So today, because our echo sessions involve a case scenario and typically also involve discussions in the didactic presentation, we want to protect individual privacy. So when sharing information about another person, avoid using any real names, including first, middle, or last names. Don't identify any family members, natural supports like friends or coworkers, any contact information, anything that could be identifying. If you aren't sure about something you can or cannot share, you can reach out to one of us on the hub team. We have this background behind us with the Echo logo, and we will provide some input. This is an echo session. It's different from a traditional webinar in that it really emphasizes participation and discussion. So it really works best when we have participation from everybody who's here. We also have a case scenario component in most of these echo sessions. They sometimes come from our hub team, experiences that we've had, sometimes come from presenters, but we are also always looking for case presentations from our attendees. And if you haven't provided one, if you would like to, please consider doing that. We'll have some more information later on. As I mentioned, this is different from a traditional webinar where we're really looking for participation and discussion. It's more of a community of practice and knowledge sharing scenario. We will have a didactic presentation followed by a case presentation with feedback and a group discussion. If you do want to submit a case study, it's an opportunity for sharing information about real life situations, gathering feedback from the community here. And if you are interested in submitting a case scenario for discussion, you can email our MHIDD@aggies.ufcu.edu email, and we will get back to you. We also offer CEUs from the Utah Social Work Association. So you can request those CEU credits through our survey. That link was dropped in the chat earlier. We'll add it again later in case you joined after it was shared. If you would like a CEU certificate, you need to fill out that survey. We also offer a certificate of attendance if you would like that. And to get that, you need to fill out the survey as well. We really appreciate feedback on the survey. It helps us make these sessions more meaningful. We do have a Canvas page. If you'd like to join, you can have access to all of our previous sessions. We have recordings on there, as well as the PowerPoints and any feedback or resources that were shared. If you'd like to join that Canvas page, you can send an email to mhidd@aggies.usu.edu. And if you do that, if you would add Echo MHIDD Canvas registration request in the subject line, that will help us get that done quickly. We do have social media pages. We have other echo sessions running as well. So if you have interest in any of our other topics, this is where you can find information about how to register for those. We have a Facebook and an Instagram, and this QR code will take you to that social media. And these slides are uploaded. I can share these slides if you want the social media information or the QR code later on. The quick input for our next session will be March 11th. And this will focus on autism in females and concurrent mental health conditions. I have a flyer that we have been distributing. If you're interested in that, in getting that flyer and sharing with your networks, let me know and I will share that with you. Some quick background on our presenter, who is Dr. Ann Kirby. I'm very excited. She's an associate professor of occupational and recreational therapies at the University of Utah. Her research centers around individuals on the autism spectrum or with other disabilities to understand family experiences and factors influencing participation and quality of life. Currently, her research is most focused on suicide risk and prevention in autism and supporting autistic youth and their families to experience successful transitions to adulthood. She has lots of experience in clinical settings, including as an occupational therapist in early intervention and inpatient occupational therapy. And I will turn the time over to you.
Great. Thank you so much for inviting me to be here today. And let me share the screen. Can you see it? Great. Wonderful. Thank you so much for the invitation, allowing me to present to you today about suicide risk and prevention in the autism community. I'll talk about what we know from existing research as well as a project that I have ongoing as well. I just want to share some suicide prevention and crisis resources in case you're not aware of them for you or someone you know or your clients. Especially wanted to point out the second from the bottom, Safe UT Frontline is specifically for healthcare workers and emergency service providers. And so that may be particularly relevant for folks here today. And I also wanted to make a note about the language that I typically use. So, you know, a lot of us, myself included, were trained to use person first language. So always saying child with autism or adult with the ASD. But a lot of the autistic people that I work with and that I know prefer to use identity first language and prefer me to use that as well when I'm presenting. So I tend to say autistic people and autistic community because of that preference. This is just a cartoon drawn by an autistic woman who kind of shares why she likes that. If you're interested. So just some background on suicide. It is considered the second leading cause of death among young people, 10 to 34. We have seen rates on the rise. There was a slight dip during kind of the height of COVID, but it has gone back up again. We do generally in the whole population see more suicide deaths among males than among females. Kind of a similar ratio to what we see in autism as well, which we'll talk more about. But then females are believed to attempt suicide more often, about 1.5 to 2 times. This is a map of the US with the latest CDC sort of estimates of suicide risk around the country. Utah used to be the darkest red, so we have seen a change there. Although we, again, do see a rise in risk, so it may be that it's just rising in other places more, which is notable. But we are one of the darker states, but no longer, you know, in that group of the darkest. So you're aware. So I hope that we've moved beyond what was, I think, prevailing idea for a while that autistic people and people with other developmental disabilities are not at risk for suicide. Things that people often believed, but are myths, are that autistic people don't have enough sort of social awareness to be affected by some of the social risk for suicide, like bullying, exclusion, or loneliness. There's also a myth that only, quote unquote, I don't like this term high functioning, but it's definitely pervasive. And there's a belief that only the more high functioning folks would be at risk for suicide if there is risk. And then as I alluded to, males are more likely to have autism and more likely to die by suicide based on the evidence we have in the whole population. So I think an easy sort of assumption people could make is that we should really be focusing on autistic boys and men. But all of those things are myths, and I'll talk more about that. So several studies have shown, kind of countering those myths, that there are really high rates of suicidal thoughts, suicidal behaviors, and suicide attempts in community samples of autistic people. So some research has shown up to 47% of clinical groups of autistic people have had a suicide attempt. Up to 72% have had some ideation. And we see numbers that show maybe a 3 to 5 times elevated risk compared to non-autistic samples. And research has also shown that co-occurring mental health condition diagnoses do not sort of fully account for those differences between autistic and non-autistic groups. So even considering high rates of co-occurring depression, co-occurring anxiety, et cetera, these we still see differences between autistic and non-autistic samples. There was one large study done in Sweden several years ago now, and they found really high rates of suicide death among people with an autism diagnosis. So the autistic Swedish people were 8 times more likely to die by suicide than non-autistic Swedish population. And they also in that study looked at differences related to co-occurring intellectual disability. And I want to point out that, again, referring to that myth before, people without intellectual disability, so if you're autistic and had an average or above average IQ, those folks were over 9 times more likely than the general population to have died by suicide. But people with intellectual disability were also more likely than the general population. They were over 2 times more likely. So we may see it more commonly in those without ID, but definitely relevant and higher risk for both groups based on this study. So I want to point that out. There's also a lot of reasons why people with ID might not get labeled as dying by suicide in their record. So that might be an underestimate too. And then we were able to, a few years ago, do a study looking over a 20-year period here in Utah, looking at suicide deaths among people who had an autism diagnosis. And this article is available for free online through Autism Research. I'm happy to share it as well. So using kind of several restricted data sets, so all very kind of privately conducted. We don't know who the individuals are, but they were securely linked. We were able to look across that 20-year period, and we found between 1998 and 2017, 49 individuals in Utah who had died from suicide, who had had an autism diagnosis in their records. And that's compared to the whole Utah population. And so in some of those earlier years, we didn't see a difference between groups. So we've seen a growth in incidence of suicide in the autism group over time compared to the non-autistic group. And some of that might have to do with, how diagnostic rates have changed and several other things that have changed over time. But as I was putting this together, I was thinking it's definitely time for us to look at the next 5-year period here, so 2018 to 2022. So hopefully we'll be able to start looking at that soon, because again, I think with all the things that have changed over time and the general suicide risk increasing, I think it's really important for us to understand how this might be changing further over time. I'm going to tell you a little bit about those 49 folks. So 42 of them were male and 7 of them were female. Among the people who died, the age range was 14 to 70. So we see the full range of sort of adolescent to adult folks. So I think that's really important. I think, I would expect younger and older as well, but that's what we saw in this particular study among these 49 people. I also want to point out that there was a really broad spread of death certificates collect data on work. And so about a quarter were students, listed as students, about a quarter were listed as employed, 10% were listed as not working. And then that data was missing for about almost half of them as well. So, I think one thing I heard a lot in earlier years doing this work was, well, the reason suicide risk is higher is because autistic people can't get work. And, while I think that's an important thing to consider, that's certainly not what we see here, that just plugging people into jobs would have prevented this, because we see this full range. So just want to point that out. And then speaking to sex differences, across that Utah study and our Swedish study, we saw that autistic females were at significantly greater risk than non-autistic females. So our Utah study, we found autistic females were at 3 times greater risk than non-autistic females. And in Sweden, they found that autistic females were at 13 times greater risk. So definitely seeing a different pattern than what we see in the general population, where, remember, I said that men were more likely to die by suicide, and there was a big difference. Here, we see actually that men and women have similar risk. And so that difference that we see in the general population doesn't translate. But there's no evidence that autistic females are at greater risk for suicide death than males. So just want to point that out. We see roughly similar. So to me, it really just emphasizes that we need to be thinking about males and females the same way. Whereas in the general population, some of our traditional training might not have trained us that way. But when we're thinking about autistic populations, we want to think about everyone potentially being at risk. Also just want to briefly mention methods. I don't like to talk too much about them, but I think a lot of times we think about firearms as a really common risk for suicide, and they are in the general population. But what we saw here was that autistic people were 3 times less likely to use a firearm, but again, more likely to die by suicide. So, restricting access to firearms, again, might be a really important practice that we're thinking about clinically, that we're thinking about from a policy perspective to help prevent suicide, but it may not be sufficient when we're thinking about autistic folks. So probably still important, but not going to solve the issue here. I also want to talk about co-occurring conditions. I know that this group is really interested in sort of the co-occurrence of mental health and developmental disabilities. And so that is something that we wanted to look at here. So we compared people who were autistic and died by suicide to people who were non-autistic and died by suicide, and looked at rates of health conditions. And we saw the autistic folks were significantly more likely to have all of these conditions listed here: depression, anxiety, bipolar disorder, post-traumatic stress, and OCD. So we're seeing a really high rates of co-occurring conditions, and even compared to other people dying by suicide. And I did compare these to one of the largest studies that has been done on health conditions among autistic adults. And so we can see here the red lines are where Lisa Crowan's study had found the rates that they saw among autistic adults in the Kaiser Permanente health system. And so a lot higher than we'd expect based on their autism, and a lot higher than we'd expect based on them dying by suicide. So interested in the overlap there, and definitely thinking about, you know, really paying attention to suicide risk among folks who have all these different co-occurring conditions. We also wanted to look at co-occurring other kinds of conditions, not just those mental health conditions. So we also did the same thing and found similarly high rates of ADHD, sleep problems, psychosis, personality disorders, and over 50% substance use problems. So that really stands out to me as well. And similarly, we looked compared to those rates reported by Lisa Crowan's work. And again, we see much higher compared to what we'd expect based on their autism, and higher than we see compared to other people who've died by suicide. In terms of specialized resources, I think this is right. The first thing we think about is, okay, so now we know there's a problem. What can we do? There is work going on. So there is, I'm aware of research going on, working on tailored screenings. So those are being studied right now. There's ongoing work on tailoring some evidence-based interventions. People are trying to do some tailored cognitive behavioral therapy, dialectical behavioral therapy, and other approaches like that. And then my team is currently working on community-based educational intervention. And so our goal is to work with community-based organizations that serve autistic people to provide them with education and resources, and sort of empower them to be thinking about suicide. So we want to get the information to people who are working with autistic people on a regular basis and kind of thinking about community more broadly. If anyone's interested in learning more about that, definitely reach out to me, because I will be recruiting organizations soon. And there has been some work done to look at what clinicians' perspectives are about working with autistic people who might be at risk for suicide. So clinicians said that they would probably be less likely to recognize or perceive that their autistic clients were at risk for suicide. They reported that the Columbia Suicide Severity Rating Scale was the most common tool that they use. Clinicians reported having lower self-efficacy when screening for suicide risk. So they're not really sure, they're not confident in what they're doing. And they, in general, felt like the interventions that exist, safety planning interventions, cognitive behavioral therapy, et cetera, are more acceptable, or more things that they feel more comfortable using for their non-autistic clients. And they feel less confident and aware of what to use with autistic clients. So I don't know if folks in the room feel that this relates to their experiences, but I expect that you may feel have thought some of these same things before. So what do we know that can help? There's work going on with looking at different sort of theories and models that might help us think about this, understanding what some predictors are, co-occurring problems, co-occurring experiences that we might need to be aware of, as well as relevant interventions. So I'll talk about sort of what we know at this point, but this is really an area of, there's been rapid growth, which is good, because this is a really important topic. It's really important to the autistic community. They often rate it among the highest things that they want to see research about. And so there is research happening, and hopefully even more coming down the pipe as well. So this is a conceptual model that's been put out by the American Foundation for Suicide Prevention, really helping us think about what are all the different things that go into suicide risk? First thing that they talk about is biological factors. There are biological things that sort of predispose someone for suicide. There are psychological factors that can make it more likely that they may have suicidal thoughts. There's also various social and environmental factors, life situations, homelessness, job loss, things like that can happen. All of those sort of AFSP talks about sort of it then sort of intersect with current life events. So what's going on in people's current life that might sort of trigger a suicidal event. And then if they have those sort of urges or thoughts, then combined with having access to lethal means, so again, things like firearms, but not exclusively, then can all those kind of things can come together and contribute to a suicide risk. So our team has done some work. We did look at what some of the genetic predispositions are for autism, as well as some of the genetic predispositions for suicide. And we kind of cross-matched those lists and found that there's some overlap. And so there might be some unique biological factors among autistic people that may sort of already predispose them to suicide. And then there are psychological factors that can affect the whole population, but again, autistic people may be more likely to experience, such as having motion regulation challenges. And then there are social and environmental factors, which again, anything, any social environmental factor could affect an autistic person, but they may be more likely to experience some, such as exclusion, current life events. Then all of those things can contribute to certain events or traumas or experiences that might kind of come together for an autistic person to lead them to attempt or die by suicide. So I also want to talk about another theory that's been kind of studied and talked about with regard to autism is the interpersonal theory of suicide. And this theory shows that there are several kind of aspects that contribute to a suicide risk. So one is thwarted belongingness, really feeling like you don't belong, like you're alone, like you don't have sort of community. We know that autistic people can quite experience that. Perceived burdensomeness is the second one. That feeling that someone's a burden, that other people around them would be better off if they weren't around. Those two things can come together, and the theory talks about those leading to a desire for suicide. And then the theory also talks about then, you know, so those two things on the top contribute to that desire, that maybe those suicidal thoughts. And then once there's kind of a combined with capability for suicide, then there can be suicide attempts or deaths. And that capability for suicide is considered pretty broadly, but it includes things like a decreased fear of death, decreased sort of pain response, and also access to, again, lethal means. And all of those things can, according to this theory, come together. This theory has been studied in the autistic population, and they found that especially thwarted belongingness and perceived burdensomeness have been associated with those desires for suicide. So based on existing research, some other associations and predictors that we've seen, so those two things that were just discussed as part of that interpersonal theory, depressive symptoms, and also the use of antidepressants, which is pretty much just a proxy, we think, for depressive symptoms, are things that have been associated with suicidality. So among autistic people, so things like lack of energy, crying, feeling worthless or guilty, fatigue, and sadness. emotion dysregulation, traumatic life events, rumination, so thinking about the same things over and over again, and low self-esteem are all things that some different research has found. Summarizing what I showed earlier with the graphs, just thinking about risk factors. So again, we saw these increased rates of things like ADHD, anxiety, depression, and bipolar, OCD, PTSD, sleep disorders, personality disorders, and psychosis. And then again, that we saw over 50% of the 49 people who died by suicide here in Utah over those 20 years had a substance abuse documented in their record. And this is in contrast to what I think we often think about substance abuse in autistic populations. I think they were believed to be quite low. So this might be sort of an especially relevant thing for us to be aware of. Again, there's some work on interventions and treatments being done. So this is a list of different types of approaches that are being studied and have been, people are adapting. So I just want to have those on your radar so that you're aware. But again, the idea, I think, is that these things, as they already exist, might not be ready, but they need to be sort of tailored and adjusted for the autistic population. Some other risk factors in terms of social experiences are things that research has shown. So high unmet support needs, kind of the overlap between LGBTQ plus identities and the autistic population. So there's a lot of attention on that, and that is something that has come up in my ongoing research. And then masking or camouflaging, I'm not sure if people are aware of those terms, but really the idea that to fit in with our sort of neurotypical general society, autistic people often feel pressure to sort of conform and wear somewhat of a mask to fit in with their surroundings and to seem non-autistic. And then finally, autistic burnout is something that gets talked about a lot now in spaces, and it's coming up in some of our research as well. So really this idea that masking or camouflaging, not having your needs met, the daily sort of onslaught of things can really lead to an intense feeling of burnout, similar to how we talk about professional burnout. Those pressures from our jobs sort of building up over time. Autistic people feel that from just working to get by in society. And so that's something we're thinking about as well. So I did talk a little bit about this burnout already. It might be unconscious or it might be conscious. It can go sort of either way, but really serves to be self-protective. And so to address this masking, we really think about how being welcoming of autistic identity and embracing the concept of neurodiversity, which I'll mention shortly, might be really supportive and help sort of counter this. And so, yeah, again, about that burnout, which can come from that masking we talked about. Some of the characteristics are chronic exhaustion, sometimes loss of skills. So I've talked to people who didn't know they were autistic until they reached a point of this intense burnout and lost the ability to speak. And I'm hearing more and more kind of stories and situations like that. And then people in these situations might have reduced tolerance to, so maybe they were already sensory sensitive and their sensory sensitivity has kind of gotten even more intense. They can handle things even less. They can spend less and less time in certain situations. And so those might be some kind of signals or warning signs. But people there's been a study done interviewing autistic people about these experiences. And one person talked about its relationship to suicide, saying, I did not want to die. I've never wanted to die, but I needed to remove myself from the environment and take myself elsewhere. And the only way I knew how to do that was to die. So I tried. And then that leads me to, I just want to tell you a little bit about some of my current research. So we're still analyzing. We have a tremendous amount of data. I conducted interviews with 16 autistic adults who've experienced suicidality, 14 mental health providers who've worked with autistic people, children and adults, as well as 7 family members. And this study is being done in partnership with autistic community partners, so that I work with them on every step of the research. We planned the interviews together, and we're deciding kind of what to do with them together. So all that takes quite a bit of time, but that's called community-based participatory research, and I do that work with a group called Aspire. And this is our website if you're interested in learning more about the project, and we'll put updates there as we go. So again, we have a tremendous amount of data. These interviews were really rich, really important and interesting. But I want to share some of the things that have really stood out to us now, and we're finalizing, and we'll publish and share the findings when we're totally done. But discrimination, stigma, and shame, and sort of connecting to this pressure to conform to neurotypical expectations really came up a lot, and can contribute again to that concept of masking that I mentioned, and that had been shown in previous research. Social exclusion and feelings of being marginalized in society, being left out, being bullied, not having a sense of belonging or a sense of community. Again, those things tie to some of those things we already know about risk for suicide. And then we also found that individuals who had multiple marginalized identities, so maybe they're autistic and transgender, they're autistic and a person of color, maybe all 3 of those things, they can face those pressures kind of related to all of those identities and the intersections of them. Really importantly, one of the other things that came up was really just about everyday difficulties and stress. So these every day can be hard and challenging, and that really leads people to feel like they can't keep going. Having daily functioning challenges without accommodations or without support can be really confusing social situations people are dealing with on a daily basis. Being expected to function in really sensory overwhelming environments, not having access to coping strategies that might work. So things like self-stimulation, stimming, rocking back and forth, other things that autistic people may do to help feel comfortable, feel calm. They may be told that those things aren't appropriate in their environments. You shouldn't do that in school. You can't do that in the workplace, etc. All of those things can lead to that concept of burnout that I talked about. People also talked about traumatic life experiences. Autistic people are more likely to experience traumas, and we're also finding that autistic people may experience things that aren't sort of on our traditional list of trauma experiences, but they may experience those as traumatic and have traumatic responses to them. And so being aware of those and how those things can sort of build up for someone and contribute to suicidality. And then finally, a lack of accessible or helpful supports, kind of in general, but also it came up a lot for co-occurring physical health conditions like chronic pain, feeling like no one's ever going to be able to help them. And also for mental health conditions, untreated OCD, persistent anxiety, depression, and other PTSD, things like that. All of that without treatment, therapists, as I showed, don't feel capable of working with autistic people in a lot of situations. And so autistic people are left to sort of fend for themselves in many situations. And so all of that really contributes to just a general feeling of hopelessness, a feeling like there's no point in continuing on. And that's a really important thing to be aware of. I like to think about how can we help people who feel hopeless, but also what can we do earlier before people feel hopeless to try to support them to not reach the point where that's how they're feeling. This is a quote from one of our autistic participants. They said their feeling was of kind of just not wanting to exist anymore, completely escape everything and not exist. And they can think back to probably from maybe 9 or 10 years old, and it being very much tied to their ability or difficulty with meeting neurotypical expectations. And then another participant, I asked what they think are sort of important things that we should know as researchers. And they shared, I'd say probably the number one thing that researchers should know about autism and suicide is that it's the rule rather than the exception. If an autistic adult isn't suicidal, then they're probably doing things to push it out of their mind because it's pretty much always there because we're constantly rejected. And they also added, I'd say that's true, especially of queer and trans autistic folks and autistic folks of color, and that's no exception for me. So as I mentioned, I think it's important to talk about neurodiversity in this context, and I think that those last two quotes really, really speak to that. So neurodiversity, if you're not aware, is really a self-advocacy movement. It's generally framed around how autistic people, people with ADHD, people with other neurological conditions really are, their brains work differently than the general population's brains. And sort of using the social model of disability, talking about how it's not always their brains that are the problem, but the problem is that society doesn't sort of allow for differences in neurological functioning. And so really the idea that not all differences are bad, even though aspects of autism are disabling, that we also need to think about the environments and the surroundings of people. And so an autistic researcher who wrote about neurodiversity said there's a real desire for services aimed at improving subjective quality of life and well-being while respecting and preserving autistic ways of being, and importantly, provided at the request and with the consent of the autistic person. So really thinking about respect and honoring autistic people, what they want and their ways of being, while also offering them support for what they face challenges with. And that can be challenging, and I hope we can talk more about that in the discussion. And so from all of this research, the existing research and the research that we're doing, I've been working on with a team sort of thinking about how we need to think about prevention. I think the most common way people think about prevention is at the individual level. What can we do to help this person who's currently suicidal? And that's important. And that's, we talked about that list of interventions that people are talking about, safety planning, DBT, mindfulness, those things might all help. But I also want to talk about their social network and their community and how those things, a supportive social network and social environment, can be a really important part of prevention based on what we know. Also, services, supports, and resources, which I know the folks here today are really thinking about. How can our services, supports, and resources be neurodiversity affirming, help people to support them early so that they're not leading to, so they're not getting to that hopeless state. And then finally, again, talking about that neurodivergence and neurodiversity, really thinking about the societal attitudes and culture and how those filter down to the individual, and how can we change that so that we can prevent suicide at this sort of broader level. So those are all things that that I'm thinking about based on the current evidence. I'd love to hear folks' thoughts about that. I did want to share a couple of resources. I was a part of this group. I wasn't involved with making these specific resources, but there's a resource about warning signs for suicide and considerations for autistic people, crisis supports for the autistic community. And then Lisa Morgan is an autistic woman who led the development of both of those supports and resources. She has a website, autismcrisissupport.com. She has other resources there. So I encourage you to check those out. She's always building on that, trying to get information out to others to support the community. So some take-home messages on autism and suicide I want to share. So first of all, that suicide is something that we should be paying attention to among autistic community members, and that there is that evidence of higher incidence of suicidal thoughts, suicide behaviors, and suicide deaths in the autistic population. Again, that those neurodiversity perspectives and thinking about respecting and honoring different ways of thinking and being can really potentially help with that societal attitude, but also help individuals feel more belonging and less hopelessness. And thinking about those multiple levels of prevention and thinking about them early. I think if we only think about people once they're in a crisis situation and we're already that the only thing that feels like a solution is for them to go to inpatient psych settings, that puts them in a potentially risky situation. So thinking about what we could do before we get to that point. And certainly that more research is needed. There's more research going on, and we're continuing to do work. And then in terms of clinical implications, first of all, if autistic people tell you that they're suicidal, believe them. That's the most important thing I could share based on the interviews that I've done. Don't discount suicide risk in autistic people. Think about autistic people being at risk no matter what their sex or gender identity is. Think about it for people with and without intellectual disability, speaking or non-speaking, etc. For the whole community, we need to be thinking about this. More specifically, we can think about screening or assessing for suicidality, as well as some of those various things that I pointed out as risk factors: depression, emotion dysregulation, substance abuse, trauma, low self-esteem, and quality of life issues. Think about doing safety planning and doing it early before there's an issue, before someone's in a crisis. And also consider environmental risks. What are the things if someone's surrounding that could put them at danger? Identify and help people meet their support needs. Again, remember, unmet needs are a risk factor. Daily challenges are a risk factor. And so helping meet those needs and reduce those daily challenges can be a really important thing to be thinking about, not just crisis, but what can we do to help people in their everyday lives. Think about avoiding, reducing, and addressing things like trauma, burnout, rumination, and social isolation. Again, those are all risk factors that we see. And then finally, again, really thinking about taking that neurodiversity affirming approach. I'm very open to questions. I really appreciate the opportunity to share, and I'm eager to chat more with you all. And this is my email and my Twitter handle if either of those are ways you want to reach out to me.
Thank you so much, Anne. There's a lot of really important data and stories told there. If anybody has a question, feel free to unmute and ask. You can add it to the chat. It looks like we do have a question coming. We have a question for Matthew in the chat. Do you have any recommendations for assessments with nonverbal clients?
Matthew, that's a really great question. So when you say nonverbal, do you mean non-speaking or no access to language?
Yeah, non-speaking primarily. Sometimes we have people come in that are having suicidal thoughts, ideation, and we need to assess.
Mhm. Yeah, so I would, if people are using AAC or other sort of alternative means, I would definitely consider it similarly to trying to work with speaking people. Um, we have a non-speaking team member on our research team, and she's a really strong advocate. She talks a lot about how she feels that non-speaking people are just the only solution ever really offered to them is medication. And she really feels like she wants access to the same kind of um, other therapeutic approaches and understanding that other people do, even though it takes a lot longer for her to communicate. And she communicates with a communication partner, but she really doesn't want to just be medicated, which is a lot of the situation. So that can be a challenge, but I do think taking the time to ask them, to listen to them, in using whatever means of communication does work for them. It's harder when people have really limited access to communication overall, so they don't have a reliable alternative way of communicating. Um, in those situations, you know, some of the mental health providers I talked to spoke about how they've learned a lot from their speaking clients, and their clients, you know, with less significant challenges with communication, and they've been able to sort of learn what might be going on in their head and to um, kind of allow space for them to feel, you know, try to express emotion in the way that they can, and working with caregivers to try to understand changes and, you know, things that might be supportive. But really, I think a kind of collaborative approach with caregivers is required when there isn't really reliable communication. And that can be hard because, again, I don't think these are people who aren't experiencing suicidality. They just aren't able to necessarily share about it. And so, you know, trying to get creative and think about, you know, what works for supporting them in other ways. But if anyone else in the room has thoughts or ideas, I'd love to hear them, because it's not a group that I have worked very, very much with. So
I reached out to we have a Cache Valley's supportive employment team that works with some of these folks, and we have been looking into some of you have the picture tablets and things like that that you can have
mhm.
where they can point and make sentences now where it speaks the different languages they're pointing. So we are looking into some of those technologies. We haven't committed to anything in particular. That's just why I was wanting some feedback and thoughts about that.
Yeah, and I think, you know, when thinking about, I mean, there's an organization called Communication First, which again, the non-speaking member of my team is a really strong advocate and supporter of that organization. They really advocate for prioritizing communication and finding a way for people to communicate. And some of the challenges, I think, with some of those technologies is, you know, the options are often limited and don't allow for people to convey really what they want to communicate. And so thinking about, you know, not just bathroom and food and sort of basic needs, but is there room for trying to think about how they could convey emotions and how they're feeling, and that they're frustrated or that they're feeling hopeless. And really, again, it can be hard, but that could be the thing that someone wants to communicate most, and you're presenting them with a bathroom button, and that's just not the thing that they care about at that time. And so trying to think broadly about all the possibilities, and perhaps working with the autistic community or other people with developmental disabilities and their family members to figure out what are all the things that might want to give people access to communicating about.
Great, thank you.
Thanks, Dan and Matthew. We have another question from Eduardo in the chat, which is, what is your opinion of ABA services? Some people are not quite supportive of those for diverse reasons, while it is still highly practiced and offered among the autistic population. Are there any considerations in terms of recommending ABA services for a high-risk autistic client?
Yeah, it's a great question. It's complicated, and I'm sure there's a lot of different opinions in the room here. I have, I don't know that my opinion is really the most important. I know that autistic adults have often talked about negative experiences with specifically programs and services aimed at making them less autistic. And so that might be ABA, but it might not be ABA. So ABA can be used to address a wide range of things. And so, I think more specifically, I have concerns around things that are really aimed at making people seem less autistic. So if the focus of your services are making eye contact and not something that matters and is really meaningful to the autistic person, then that can be something that can lead them to feeling some of these things that I mentioned, can feel like masking, can feel like they're just trying to conform to neurotypical expectations. They'll never fit in, again, hopelessness. And so my recommendation is really thinking less about, what programs are sort of labeled. And even, I think when someone evaluates someone for autism and just writes recommendation ABA, what does that really mean? And what is really the recommendation? And I think being a lot more specific is really valuable, and recognizing that services that are aimed to reduce someone's sort of aspects of their identity and is less focused on helping them meet kind of their daily needs could put them at risk, could further their risk. And so that's my take. And I think that's really important based on all the interviews that I did.
Okay, thank you, everyone. If you have questions later on, feel free to put them in the chat. I will also share these presentation slides on the Canvas page later on, so her contact information will be available there. We're going to move on to the second portion, which is our breakout group discussion and case scenario. So before we go out into breakout rooms, I'm going to provide the case discussion for today. This is based on my experience managing residential habilitation services. So the context for this is a disability services setting. The background on this case, we are working with, and these details have been altered to protect privacy, but we are working with John, who is a 26-year-old autistic male with mild intellectual disability, who currently lives at home with his parents and 3 younger siblings. He receives 15 hours of community-based services per week. Sometimes he remains in his home for those services and sometimes goes out into the community. He becomes irritated easily and has a history of angry outbursts. John also has a history of negative self-talk following these outbursts and takes a while to de-escalate. John's parents are currently his legal guardians, and he attended talk therapy sessions for a few months when he was a teenager, around 16 years old, when he was referred to counseling by a school counselor, but he stopped going because he said it was boring. The primary area of concern for John is that the angry outbursts have escalated in length and severity over the past few weeks, so this is a recent change. And in the most recent outburst, he grabbed a knife and told support staff that he was going to hurt himself. After de-escalation of that setting, John repeatedly stated, "I can't take this." John's parents don't believe that he is a danger to himself. They think that this behavior is solely attention seeking, but John's support staff are concerned that he may actually cause harm to himself. The goals and barriers specifically in this scenario, the goals being in his person-centered planning meetings, John has told his care coordinator that he would like to have fewer angry outbursts because he doesn't like the way that he feels afterwards. It's very stressful. His parents have said they would like to see him develop skills to prevent or reduce the negative self-talk that happens. Some barriers to that is that John does not believe that his negative self-talk is a problem or a contributor. And John's parents have told his care coordinator that they don't know how to talk about self-harm and suicide and that those topics make them uncomfortable. So with that background information in mind, if you have any questions, feel free to ask and I will answer them if I have the information. But we're going to address these 4 questions. What we'll do is split up into 2 breakout rooms, and each breakout room will have 2 questions. I'm going to put those in the chat now, so you should still have them when you go to your breakout room. Breakout room 1 will answer the first 2 questions. And breakout room 2 will answer the second questions. In your breakout rooms, if you will choose somebody to take some notes and then share with the group afterwards, that would be great. We're going to compile our case recommendations, and these will be shared on our Canvas page and also, of course, here in our group for anyone to use in future cases. I will set a timer for about 10 minutes, maybe slightly longer. Welcome back, everyone. I think we've got everyone back here. We probably needed a little bit more time for those questions, but now when we go over them, we'll have a little bit more opportunity for group discussion, because when we're bringing these two groups together, there might be some input also from each group. So we'll start with question number 1. How can direct support professionals and John's case manager / care coordinator address the topics of self-harm and suicide with John and his parents? Group 1, do you guys want to share?
So I was in group 1, and we talked about really opening up the dialogue between John and his parents, getting the conversation going, working towards kind of everybody having the same understanding of, what's going on for John. And yeah, I think just opening that up first thing. There's a lot more there. He's not in therapy anymore, so talking about, if there's interest there, both for him and possibly family, to work on some of the family dynamics that are occurring when he's having kind of an outburst at home, and really working to identify what his unmet needs are and how to address those.
Thanks, Penny. I like that you brought up unmet needs, because we did talk about his parents do perceive this as an attention-seeking issue, so it would be important from their perspective to talk about unmet needs. Does anybody want to add anything from group 2 or anybody else from group 1?
From what I read, and it sounds like some motivational interviewing would be beneficial, because on the one hand, he doesn't want to address his negative self-talk, but on the other hand, he feels guilty after he behaves in an angry outburst, and his negative self-talk are likely increasing his tendency to do that. So.
Yeah, great point. Thanks, Daniel. Question number 2 was, based on the information in this case, is John's safety a concern? And what, if anything, should be done to support safety while also ensuring autonomy? That's kind of a big one. So I'd love to hear what you guys talked about in group 1.
Right, so definitely a concern, especially since it's been escalating and becoming more frequent. And we did also kind of talk about developing sort of a reward system to kind of motivate his participation in therapy and some of these other things, which I think kind of coincides a little bit with what Samuel was talking about with motivational interviewing. We also talked about referring parents and even his siblings to support groups for themselves. Yeah, sorry, I'm just looking at my notes, we just had one big conversation, so I'm trying to parse out what's question 1, what's question 2. We talked about kind of helping him identify his interests and things he likes to do as part of the sort of reward system, but also to increase engagement in the community and help bolster a sense of belonging as well, to hopefully address some of that.
Yeah, that's a great point that touches on that importance of feeling belonging, as Anne talked about in her presentation. Moving on to group 2, that second set of questions. The first was, what elements of suicide prevention can be addressed for John? So that goes back to Anne's presentation as well, those community factors, individual factors. What did you guys talk about regarding that question?
So it was suggested to really clarify and directly ask, is this a suicide ideation or self-harm? So being very direct and clarifying that. We also discussed considering looking at the Thomas Joyner model of thought belongingness and perceived burden. Really looking at who are his supports, what are the things that bring him meaning in life, and then also distress tolerance. What is his level of distress tolerance, and is there a way that we could potentially help him build that up? Do you want me to go into the next question, Rachel?
Awesome. Thank you, Ashley. Yep.
Okay.
It says, should John be referred to mental health services, and how can this be addressed with John's parents who think his behavior is solely attention seeking?
Yeah, so we had the conversation of providing psychoeducation on disability and suicide for his parents, and just general suicide psychoeducation. So going over what are risk factors, particularly the fact that he has autism, but then also going over what are the protective factors that you can have, and helping them understand how they can assess his suicide risk, and helping them understand it does fluctuate. This isn't a static state. And then really, truly, if attention is the driver behind his behavior, what can they do to proactively kind of address this and provide a meaningful interaction with him? So again, going back to, I think it was Penny's conversation or comment of what are the unmet needs?
Some great input. Thank you. Is there anything anybody else wants to add about any of the questions? And is there anything that you would add based on your experience?
I mean, to me, the most important thing with this one is like believing sort of what he's saying, and working with his parents to sort of maybe reframe how they're thinking about things, and identifying the things that are challenging in his life. I think the case doesn't tell us like, why can't he take it anymore? What are the things he's struggling with? And so really digging into that and trying to provide him with support for what he's struggling with.
Yeah, that suggestion of motivational interviewing and finding out what those unmet needs are. And I like you framed the question, why can't he take it anymore? Going beyond and addressing those needs. Good suggestion. Thank you. We have just a couple minutes left. We'll wrap up. If you have questions for Anne or myself, if you're interested again in providing a case scenario that you'd like input on from a group, this is a great opportunity. Our next session, as a reminder, will be on autism in females and co-occurring or concurrent mental health concerns. So if you have any case scenarios related to that, feel free to send them my way. I'll drop my email in the chat as well as our general ECHO MHIDD email. Feel free to reach out if you have any questions, recommendations. And again, if you would like a certificate of attendance or the CEU certificate, please fill out the survey. That link is in the chat. Thank you everyone for coming and participating. We really appreciate it. Hey, James, I can hear you, but not very well. You're a little fuzzy.
Oh, by the way, yeah, just a minute. You hear me?
Just a little. It gets pretty fuzzy.
Big tablet. I mean, I have to go with a different tablet. I have this tablet that's downloaded directly. It's hard to do it. That's great. Can you hear me?
I can hear you at the beginning, but as you keep talking, it kind of fizzles out.
sorry this last week. I had another meeting.
Oh, if we have another meeting, is that what you're asking?
No, I had another meeting.
Oh, you had another one.
I'm
That's
sorry.
okay.
I'm sorry this last week I had another meeting.
You're a busy guy. Don't worry about it.
Okay. Well, thank you.
Thanks for joining for that last part.